Hello and welcome. My name is Dr. Patrick Godbey. I'm the president of the College of American Pathologists. The CAP represents about 18,000 board-certified pathologists in the United States and around the world. The CAP also is the accrediting body for almost 8,000 laboratories worldwide. Pathologists and the laboratories we direct are on the front lines of this pandemic. Alongside our laboratory scientists and other physicians, COVID-19 tests pass through our laboratories, and we are responsible for those tests. You can say pathology is the engine that powers the testing car. This is our final media briefing for 2020, but it won't be our last. The CAP is committed to providing members of the media with the most up-to-date information when it comes to testing for COVID-19, as well as other viruses and diseases. During this briefing, we will be discussing the current state of testing, the current testing surge nationwide, and what testing will look like well into 2021. Also, how will the distribution of the imminent COVID-19 vaccines affect the testing landscape? At-home tests. Several physicians and scientists have called for the availability of these lower-cost tests to curb the spread of the virus. We'll talk about the pros and cons of at-home tests and also explain point-of-care tests. Pathologists and laboratories continue to face supply chain issues, which hamper getting timely results to patients. We will discuss changing U.S. healthcare policy, including the impending CMS two-day turnaround time penalties on COVID-19 tests. How will this affect access to care in laboratories, both big and small? We would also like to talk about the importance of pathologists within the healthcare team when it concerns decisions about who should be tested and also how they should be tested. Finally, we'd like to touch on how COVID testing has impacted testing for other viruses and diseases, including sexually transmitted diseases, and why that may cause other public health concerns. We have two CAP members joining me today, Dr. Christine Wojewoda and Dr. Amy Karger. Would both of you please introduce yourselves to our audience? Dr. Wojewoda, then Dr. Karger.
Hi, I'm Dr. Christine Wojewoda. I'm the director of the Clinical Microbiology Laboratory at the University of Vermont Medical Center, and I'm an associate professor at the University of Vermont. I'm also the vice chair of the CAP Microbiology Committee.
Good morning. My name is Dr. Amy Karger, and I'm a clinical pathologist and associate professor at the University of Minnesota, where I direct clinical testing at our children's hospital, and I also direct point-of-care testing for our health system, mHealth Fairview. I'm also a faculty investigator at the Advanced Research and Diagnostic Laboratory, where I direct COVID-19 PCR and serology testing. And lastly, I'm currently serving as chair of the CAP Point-of-Care Testing Committee.
Thank you both. All right, let's get started. Can we get a perspective about what's going on in both your laboratories? Dr. Wojewoda, you're in Vermont. What's working for you and what's not working for you in your laboratory? Give us some challenges and triumphs.
So I've felt very lucky to be in Vermont during this pandemic. Vermonters have done a very good job for a long time of following the rules and keeping people safe around them. But people in Vermont have started to get tired of following the rules and kind of let their guard down around Halloween, especially around Thanksgiving. So we're seeing our numbers spike here in Vermont now. In terms of testing successes, we've had a great relationship with the Vermont Department of Health, the Vermont Public Health Laboratory, the Vermont Association of Hospitals and Health Systems, and then we are a health network and have hospitals in New York as well. This has allowed us to have a coordinated effort of testing across the state and into New York. And when we've had issues, we've been able to shift samples to different places or share reagents. So working together, we've been able to get a lot of testing done. Our challenges have been around supply chain. A really good example of that is we put a purchase order in for an instrument to do high throughput COVID-19 testing in March 15th. The instrument got delivered to us end of September. It's still sitting in our laboratory, not doing any testing because we're waiting for the supplies, the plastics and the chemicals that we need to perform patient testing. So that's just one instance of we're trying to do as much testing as we possibly can. We just can't get the supplies that we need to do that.
Dr. Karger, you're in Minnesota, which is a hot spot. Can you also share what's working and what are some of the challenges in your laboratory?
Yeah, absolutely. So you're correct. We've had our peaks with hospitalizations, fatalities, and cases within just the last couple of weeks. And so testing needs are at an all-time high. We are very fortunate with our laboratory at the University of Minnesota that we have spent the last several months since March preparing for this surge. And so we are able to provide enough testing capacity in-house for our health system, which is we're really an outlier in that regard. How we got there and what's worked for us. In the very beginning of the pandemic, back in March, a team of 2 pathologists led an effort to develop an in-house test for COVID. And that was critical for us in that we didn't have to rely on any single manufacturer for a test. They got that test up and running in 6 days, which was really remarkable in terms of how quickly they were able to get that up and running. And they also built a lot of redundancy into the testing such that we could use different supplies and different reagents and chemicals. If one ran out, they validated the performance of other options so that we weren't reliant on just one supplier. Other things we've done, similar to what Dr. Wojewoda mentioned, we've also, at the same time as having our own in-house method, have also purchased numerous instruments from manufacturers to have redundancy in our testing. Similar to her experience, there's one instrument that we purchased back in March that we still haven't gotten supplies for, but there are others that we have purchased that we have been able to get limited supplies. And so that has allowed us to expand our testing capacity in that way. And the other thing that's allowed us to be successful is availability of space. So whenever you're setting up a new lab, space can often be a major barrier impediment to that. When we first got started, researchers at the University of Minnesota lent us their research lab space, which was very generous of them. They let us set up a testing lab in their research lab area, but we knew we couldn't stay there forever. And so what was really fortunate for us is during the summer, it just so happened that a tenant vacated a space that turned out to be an ideal location for creating a permanent testing lab for COVID. And that has really helped us in terms of expanding our testing capacity to the level we're at today. So we were able to build out a lab space within a couple months' time and move that temporary lab into a permanent space. And so we've been very fortunate with some of these things happening at our location that has allowed us to provide testing for our health system. But there still remain challenges. We're constantly battling supply chain, as Dr. Wojewoda mentioned. It's a daily battle. One of our managers spends hours a day making sure we have enough supplies, plastics, chemicals to do the testing that we want to do. And he's often having to look for alternative solutions for testing, making phone calls, trying to find alternative products. And so we have a consistent worry about that. And then I would say the last thing that's been a major challenge and concern of mine is staff burnout. Our lab staff have been working full throttle since March, and I think that's something that's often lost on people. They kind of assume that when cases were low with COVID that maybe the lab staff got a break. Well, that wasn't the case. They were planning for this surge that we're experiencing now and have been working often 7 days a week, double shifts to get us to this point of high testing capacity. And so I do have concerns about my staff because they have not had a break since the spring. Once we got our testing capacity up, we were immediately hit with all this increased testing capacity with the surge we're experiencing now.
Our experience in Georgia is in many ways like both of yours. We got testing up as quickly as possible. We had 2 different methodologies up in our lab in March, but still, we cannot get enough reagents, we cannot get enough plastics or consumables to perform all the testing that we would like to do. We've compensated and adapted as best we can. Some examples are we do have 2 platforms, 2 separate types of machines. And if you think about it, ideally you would have one and duplicate that type of machine. Your laboratory scientists need to be proficient in one type of machine rather than 2. Your maintenance contracts and maintenance on the machines are one type of machine rather than 2. You purchase reagents from one source rather than 2, and reporting is uniform. But because we cannot get enough reagents and consumables, then we have to bring in more than one type of platform, which negates many of those advantages. Why do we do that? Because if today, and as Dr. Karger said, this is a daily exercise. If today I can get reagents for platform 1, but I can't get them for platform 2, then I run platform 1. If I can't get them for platform 1, then I run platform 2. Another thing, or another way that we have learned to cope, and again adapt and do the best we can to answer the testing needs to take care of our patients, is to use more than one reference lab. We ideally, if you have to send a test away, you would use one lab, one courier system, one reporting system, one place to go for tests that you have sent away. And when I say a reference lab, I'm talking about a lab that is usually 3 to 4 states away from us, which also introduces increased turnaround times. But we've learned that we have to shop reference labs. For instance, if today LabCorp's turnaround time is 2 days and Quest's lab turnaround time is 4 days, we'll use Quest. But we continue, we'll use LabCorp, but we continue to monitor the turnaround times and shop reference labs. Is that ideal? No. But again, we are forced to do that to adapt to the needs of taking care of our patients during the pandemic. Dr. Wojewoda, let's talk about what local plans and practical solutions your laboratory is using to solve testing challenges. I've talked about some in mine.
Yeah, so we also have multiple testing platforms, and just like Dr. Karger's lab, we've developed a test in-house. So we worked with our genomics laboratory to bring in a laboratory-developed test. We are looking at purchasing a second set of instrumentation so that we can double the capacity for that test. We also have 2 tests in the clinical microbiology laboratory, and we're sitting on that instrument waiting for reagents for the 3rd. But because of supply limitations, we still can't keep up with all of the samples that come to us. So we have to send some of our samples out to a reference laboratory. And again, that diversification that you spoke about, Dr. Godbey, and if we've got supplies for one but not the other, we run everything on the one platform, has been useful to keep testing going, especially for the most critical patients, the symptomatic patients in the hospital. Those are the patients you really want to have answers for the fastest. So we just keep trying to increase capacity and move samples around whenever there are issues.
Dr. Karger, what about you?
Yeah, so great question. So we have been fortunate to have a strong effort from our Department of Health in Minnesota to coordinate testing statewide, and that's really helped us beyond our health system to help out the state of Minnesota. Early in the spring, they tapped both the University of Minnesota and the Mayo Clinic to create a testing command center to help coordinate testing efforts across the state, recognizing that some rural communities don't have as much access to testing. And so this testing command center has been in operation since the spring, involves representatives from all of the large healthcare systems across the state, and has really helped us coordinate efforts to lend testing capacity to others in the state of Minnesota. And in fact, right now, we're providing more tests for the state of Minnesota than we are for our own health system because we do have that excess capacity. I did want to talk too about what you mentioned with having multiple instruments and some of the challenges with that. We have found it particularly challenging because we have had to hire so many new people. And in an ideal world, you would like to just train new people on one method, but we're having to train new people on multiple different methods. And so that makes their job as new employees even more challenging in the lab to have to learn how to do a COVID test in 2, 3, or 4 different ways. And so that's another challenge for us in the lab that we have to overcome. And then the last thing I wanted to mention is, the testing part for us is easy in the lab. We know how to do the test. We know how to get the results out. But a lot of times the challenges come outside the lab. And one of the big challenges we've faced is collections and having enough people and manpower just to do collections. And so one of the solutions we've had with our health system is creating a swab squad. This was a group of lab staff who created a mobile testing unit. So they would take PPE and swabs and go out to long-term care facilities and do collections. And so we've had to come up with creative solutions like that to be able to get the testing done in some locations that aren't necessarily connected to a healthcare system.
Your points are well taken. We have the same problem with using multiple platforms. Earlier, you mentioned burnout among laboratory scientists. We worry about that as well. It has made this demand for COVID testing has made an already bad situation worse because there's an absolute shortage of laboratory personnel, and the increased demands on lab have made this shortage even more acute. Let's turn to COVID-19 and the flu season. Where are we today when it comes to mixing COVID-19 testing with other tests? Are there any of these tests currently on the market? Dr. Karger, you want to start?
Yeah, absolutely. So there are multiple options available for testing for both flu and COVID at the same time. And in fact, our health system has gone live with one of those options in our microbiology laboratory. And we are also planning to go live with a point of care version of that, a rapid combination test as well. One good thing, silver lining of the social distancing and masking is that we aren't seeing much in terms of flu cases, which is great because we really don't have the capacity to handle those in our hospitals and clinics right now. So it's nice to see that influenza is really at fairly low levels compared to usual.
Dr. Wojewoda?
Yes, we've also gone live with a combination flu, RSV, and COVID-19 test in the past few weeks, right around Thanksgiving. We also have the ability to test for flu and COVID-19 on one of our larger platforms, not at the same time, but using the same sample. I agree. The silver lining is that we're not seeing flu, and I'm keeping my fingers crossed that pattern continues. Again, just encouraging everybody to appropriately wear your mask and social distance, et cetera. I think the downside with those tests is that there is no indication for testing an asymptomatic person for flu or RSV. There's no asymptomatic shedding in those viral infections like there is with COVID-19. And so because of the limitations on supply for flu testing, we had to limit the use of those combo tests to patients who are symptomatic. And so that decreases our supply for asymptomatic patients that we want to test for COVID. We've worked with the state to put out some guidance around who to test for flu. Really a healthy person with no risk factors doesn't need to get tested for flu. They would need to get tested for COVID-19 if they're symptomatic or if they have any exposure or travel, but they don't need to be tested for flu. And so trying to educate our providers around who needs flu testing and who should just get COVID testing has been a big push for us recently.
Let's turn now to point of care testing and at-home test. Dr. Karger, can you explain what at-home testing means and how all these different types of tests work?
Yes, absolutely. So I'll start with talking about point of care tests and how they differ and what they have in common with at-home testing. And so point of care testing is rapid testing that's occurring when a patient presents to a healthcare setting. So for example, a clinic visit, maybe they're in the hospital. These point of care tests are performed by a healthcare provider or personnel who does the test at or near the location of the patient so that they have that result during their visit, and hence why they're called rapid tests. So they have the advantage of giving an immediate answer. There are disadvantages to point-of-care tests, however. Typically, these can only be done one at a time. You can't batch them and run large groups of tests at once like you can on an instrument in a central laboratory. And so staffing can be an issue in terms of doing a lot of point-of-care tests. The other disadvantage is they do tend to be less reliable than the central lab method. So accuracy can be an issue, and that will vary depending on the point of care test. Now, at-home tests are another form of rapid test, but they are performed entirely in the home by a layperson, by the patient. There's no healthcare personnel involved in the testing process. And in the strictest sense, these are tests, at-home tests are tests that are collected and performed such that the patient gets the result in their home. And I say that because there's been some confusion about at-home testing because a lot of labs are doing at-home collections where the patient collects a swab or saliva sample in their home, but then they are mailing that sample to a lab for testing. So that's just at-home collection. At-home testing in its strictest sense, the patient gets that result themselves at home. Currently, there's only one at-home test for COVID-19 that's been approved by the FDA under the EUA, but it hasn't really had an impact on the testing landscape because these tests are not yet widely available and they won't be available until the spring. And so it's yet to be seen what sort of impact at-home testing may have. But there are many point-of-care tests, rapid tests being used in healthcare settings right now. In terms of how these tests work, again, there are similarities between point-of-care rapid tests and at-home tests in terms of the technology. The at-home tests that are under development typically will detect the proteins of COVID-19 or the genetic material, and the point-of-care tests used in clinic settings are the same. But at-home tests have to be the simplest version of point-of-care tests because there isn't a healthcare person involved with running the test. And so some point-of-care tests are far too complex really to be used in an at-home setting. So those are some of the differences between point-of-care and at-home tests.
Dr. Wojewoda, do you have any concerns about these tests?
My biggest concern is that specimen collection is done appropriately, especially in the at-home collection or at-home testing types of tests. We know that if a specimen isn't collected appropriately in any type of lab testing, that's going to introduce the biggest chance for an incorrect result. And so having patients really follow the instructions to the letter is very important to get a correct result. And then if it's a full at-home test, really making sure that each step in the test is followed appropriately. And if anything goes wrong, you stop and get a new test in order to not have an incorrect result.
Let's move on to something on everyone's mind, the COVID-19 vaccines. What role do you see pathologists and laboratories taking when it comes to national vaccine distribution? Dr. Wojewoda?
So my highest priority is making sure that laboratory staff are among one of the first groups, maybe not necessarily the first group, but one of the first groups vaccinated. Phlebotomists, people that draw blood, are patient-facing, and so ensuring that they are included in that patient-facing group. and then laboratory staff, the medical lab scientists that are running these tests and other critically important tests throughout the laboratory really are such an important critical role to a hospital function that they have to be protected. And Dr. Karger has already spoken about the burnout and potential fatigue of our laboratory staff. We need to keep them healthy. So I think that's going to be one of my important roles. I think we're still learning what's going to happen in terms of testing as vaccination rolls out. We know that no vaccine is 100% effective in preventing infection. And so I do think that we will be testing for COVID-19 for a while, but continuing to be nimble and adjusting as we hopefully see less infections as the vaccine rolls out.
Dr. Karger, what do you think?
Yeah, I completely concur with Dr. Wojewoda in terms of emphasizing the important role of lab staff and how they truly are frontline workers and often are forgotten. Her mention of phlebotomists is a key one. Our phlebotomists are having many patient encounters with patients who may have confirmed COVID or patients who, maybe you don't know if they have COVID or not, but they're encountering a lot of patients in all sorts of different clinical care settings, and you have to be very close to a patient to perform a phlebotomy. So they are at risk on the front lines interacting with patients in that regard. And as she mentioned in the laboratory, they are encountering and handling thousands of samples that have active live virus in them. Like I said earlier, we are getting 10,000 samples a day. So that's a lot of handling of infectious specimens. And so we do want them to be prioritized for vaccination. I think it's important. And also just from an operational standpoint, we need to keep our lab up and running. We don't want to have staff out such that we would have to decrease our testing capacity, which would have widespread impacts for our health system and for our state. The other thing I wanted to talk about is the impact of vaccination on testing needs. As Dr. Wojewoda said, we do anticipate continuing with COVID-19 PCR testing for a while as vaccines are implemented. But one question I have been getting involves antibody testing after the vaccine and whether that's going to be something that providers do. This is something that has been an active area of discussion. Will patients be tested for antibodies after receiving a vaccine? It's current clinical practice to not check antibodies after a vaccine, as you know, it's not routinely done in patients. So for example, if you went and got a hepatitis B vaccine in your clinic, your provider wouldn't check the antibody levels as part of a routine practice. Typically, antibody levels are only checked in individuals after vaccine if they have immune compromise or immunosuppression issues where there's a concern that they may not mount an expected immune response to the vaccine. Also, sometimes healthcare workers have vaccine antibody levels checked to make sure that they are immune to things they might get exposed to in a clinical setting. And so it's not routine practice to check antibody levels after getting a vaccine, but given the heightened interest in COVID testing, we are anticipating that there is going to be some increase in demand for post-vaccine antibody testing. And so we're at least preparing for that and preparing to educate our providers. And this is where pathologists are going to be very important when it comes to assessment of post-vaccine immunity, because not all of the antibody tests that are available can adequately or can assess for post-vaccine immunity. In fact, the nucleocapsid-based antibody tests will not be effective for detecting post-vaccine immunity because the vaccines are targeted to the spike protein and not the nucleocapsid protein. And so only the spike protein antibody tests will be effective for detecting post-vaccine immunity. And that's going to be a point of education that's going to need to be communicated by pathologists and lab directors so that providers know they need to order a spike antibody test if they want to check for a vaccine immune response.
Thank you. Here's something else I feel is important. Let's discuss the important role that pathologists play in the healthcare team when it comes to who will be tested. This answer is actually very complex. It's the laboratory director who has an hourly pulse on the availability of testing in that laboratory. If reagents are gone then the test cannot be offered. Test accuracy. How sensitive is the test? How specific is the test offered in that laboratory? What types of tests should be used? Should it be a PCR test? Should it be an antigen test? What role do antibody tests have in mind? Those are all important roles for pathologists, and some that only pathologists can answer. Dr. Wojewoda, what's your view on this?
Yes, pathologist's role in determining who gets testing and with what testing methodology is critical in this pandemic. I have spent many Zoom hours discussing with our biologic branch of our incident command how we're going to get testing performed, which patient populations are okay to have their samples sent out to our reference laboratory versus which samples and patient populations need a result more quickly that we have to do in-house. And when we do have reagent shortages, which patient populations can we shift around? Being involved in those decisions is extremely important, but communicating back with our physicians and the other providers around the state is a big part of my job, just trying to get them to understand the limitations. I had to say today that COVID-19 tests don't grow on trees. And I wish they did. I wish I could test everybody all the time really quickly, but they just don't. And so making sure that we are getting the most acutely ill patients tested with a more rapid test is my highest priority. And then communicating with providers so that they know what to expect. If we do have shortages or other issues come up, letting them know how quickly their patient results will get returned so that they can discuss with the patients what those expectations are and those turnaround times are. Those are constant conversations that I've been having since March.
Dr. Karger?
Yeah, so I completely echo what you both said. It's critically important that pathologists are involved at the highest levels of decision making in terms of clinical ordering algorithms. And I'm fortunate to work in a healthcare system and an institution where we were involved very early on, because I think when there's that lack of communication and they don't know what the capacity is in the lab in real time, it can cause real issues. And so we have been really fortunate to have that teamwork from the very beginning. Right now, our testing capacity is at high levels, and so we haven't had to limit testing as much as we did early in the pandemic, but it absolutely is critical and continues to be critical that we are involved in these conversations and make our providers aware of what type of capacity we have. And relatedly, we did set up a system for stat testing where we put those samples in a color-coded bag because, as you can imagine, when you're getting thousands of samples a day, it's hard to sort out the ones that have to be done right away. And so we did that through a color-coded system so that our staff could pull those stat ones out from the pile of samples we're receiving to get that testing done more quickly for those important samples.
I think it's interesting and sad in a way, because I had to use that exact same expression this morning on our incident command team. COVID-19 tests don't grow on trees. Anyway,
Yeah.
So I appreciate that very much. Finally, before we open it up for questions, let's talk about the impending CMS penalties, which will affect all laboratories starting the 1st of next year. Pathologists and the laboratories they lead are committed to providing quality tests to diagnose COVID-19 in a timely manner to patients. However, the Medicare program stands to penalize laboratories providing COVID-19 tests starting January 1st. In October, the CAP called on the Centers for Medicare and Medicaid Services to cease implementation of a new turnaround time payment policy that will cut fees for COVID-19 testing performed on high throughput technology platforms. The Medicare cut penalizes laboratories for issues outside of their control. These factors include the delivery times of off-site specimen collection, the availability of testing supplies needed to run tests. This represents a Medicare cut of 25%. Laboratories will be penalized if these tests are not completed within 2 calendar days or less, and if the majority of the laboratories' COVID-19 testing using the high-throughput technologies is done in 2 calendar days or less for all patients in the previous month. Cutting fees for COVID-19 tests when laboratories are taking extraordinary measures to meet demands for testing will do nothing to improve turnaround time. Laboratories need more resources to improve testing, not less. Officials currently with the Centers for Medicare and Medicaid Services have declined to cease implementation of the new policy. We continue to urge them to reconsider as cases of COVID-19 increase, along with the demands for testing. How do you both think this will impact the care for patients in each of your communities? Dr. Karger?
Yeah, I mean, this is a very disappointing development because we're going to be penalized for things like you mentioned that are completely outside of our control. And as Dr. Wojewoda said, we want to do as much testing as we can with the supplies we have, but the supplies are in shortage. We have instruments, we all have instruments sitting that we could be using for testing. And even the instruments where we do have some supplies, we don't have the maximum amount of supplies that we could have. Supplies are limited across the board for all of the tests. And so this is really penalizing us for not having the ingredients. It's like asking us to bake a cake and then not giving us anything to do it with and expecting there to be a cake, at the end of the day. It's not possible. The other issue that I want to point out is because it has to be 2 days from collection to results, this is going to disproportionately impact rural communities that don't have testing locally because those samples have to travel. Whenever you add travel time in for a sample, that's going to delay your turnaround time. And so this penalty is going to disproportionately affect outlying communities that always have to send their COVID testing samples to another location, either to a reference lab or academic center for testing.
As one who practices in a rural community, I can say you're absolutely correct. Another thing that it will result in is that we will have to be even more vigilant in who we select to receive a test in-house and who will have to send it out. I think it's worth remembering that if I can perform a test in-house, I measure turnaround time in a few short hours. If I have to send it out to a reference lab, I measure turnaround time in days. And right now, I can't get enough reagents to measure the tests that I would like to in hours. Dr. Wojewoda, what do you think?
I completely agree with both of your points. This disproportionately affects rural communities, and none of this is in a laboratory's control. So our reference laboratory has decided to close on the weekends. That's 2 days right there. If we don't get the patient's sample to the reference laboratory in time to be run on Friday night, it won't get run. And that I have no power in that decision. And when hospitals and health systems are already hurting because most of us shut down for elective procedures for a bit of time in the spring and into the early summer, we're already hurting. This isn't a money-making endeavor. We're trying to take care of patients. And if we don't have the resources that we need to take care of patients, we can't do that. And smaller hospitals then might be forced to close. And that's just, it's really unfortunate when we're trying to take care of as many patients as we can during this pandemic.
Smaller hospitals will be forced to close. And if they don't close, they'll be forced to curtail services that are available. Thank you both. Let's take some reporter questions. Let's see. The first is from Kevin O'Reilly with the American Medical Association. What are some common misunderstandings that ordering physicians might have about COVID-19 testing, and what can or should be done to communicate with them about the COVID-19 testing landscape? I think we've already addressed some points, but do either of you have something to add to this?
Yeah, I think,
I think, oh, go ahead.
oh, go ahead.
No, go
I was
ahead.
going to say, whenever we've introduced something new, there's often been confusion, misunderstanding, and things have been changing so quickly, especially with our changing clinical algorithms. We've had to make sure we have close communication in terms of how many tests are available and why we aren't able to test everyone. And as you said earlier, the tests don't grow on trees when they were and continue to be in a shortage. Recently, we've had confusion about sample types because we have introduced more sample types throughout the pandemic, starting with the nasopharyngeal swabs and adding nasal swabs. And recently, we've gone live with saliva testing. And so there were some concerns and confusions about, is that going to perform just as well? And so we've been very transparent about sharing that data with them and saying, yes, we do see equivalent performance in our hands with saliva testing when we do an extraction, and that's comparable to the NP swab, and we're confident in that. And so I think anytime anything new is introduced into the testing landscape, misunderstandings can occur, and it requires communication from the pathologist with the healthcare team.
Dr. Wojewoda?
Yeah, so I think this has been a really great time for pathologists and microbiologists to kind of have a light shown on us. And one of the things that has come up time and time again, anytime there's something in the media about a new game changer, everything is going to be the new game changer. We have to explain to other healthcare providers that just wait, let's see the data in real world and in real world situations, and that we in the laboratory can't just buy a test off the shelf and plug it in and start running samples through it. We have to do what's called a validation. We have to prove that the test works in our hands with our patient samples, and that doing that appropriately takes time. And so especially in the beginning of the pandemic, as soon as commercially available tests were around, everybody thought we could just start testing everybody all the time right away. And so it was a great experience to get to explain to other healthcare providers how we in the laboratory work to ensure correct patient results. And that's really what we're trying to do all of the time.
One thing that we've seen in some rural areas is the appearance of fly-by-night tests that really are questionable at best. And we've been able to advise our clinicians that this is not something they need to buy into, because after all, pathologists are the expert on testing. And so that's another way that we can help. This question is from Brianna Abbott with the Wall Street Journal. How, if at all, do you expect the demand for both viral testing and antibody testing to shift during the vaccine rollout, and how are you preparing for that now? Dr. Karger has already addressed a lot of that. Do you have anything to add?
Yeah, I mean, I think the only thing to add is that we aren't planning on decreasing our viral testing capacity anytime soon. So I think that's a key thing. We're, going to wait and see what happens. Obviously, ideally, eventually we'll reach a point where enough people have been vaccinated that the virus, the cases do go down in a more permanent fashion. But there are no plans for decreasing viral testing at this point in time, and we continue to try to expand our capacity as we are able to.
And at this point for us, we're even talking about potentially having an increase in testing around vaccination, as some people post-vaccination do feel a bit ill. I want to be clear, they are not sick. It's the immune system revving up and making antibodies and learning what the virus looks like so it can attack it if a patient does get exposed. But depending on how they present, we might have to test some of those people to make sure that they aren't truly infected with COVID-19. So I think we're going to be running testing at high levels for a while. And I completely agree. We're not having any plans to slow down testing anytime soon.
We're not planning to slow down testing any either. We're trying to get all the reagents and offer more testing. We don't see the demand for testing going away. This question is from Scott McCartney with the Wall Street Journal. Some states and countries are requiring negative tests for entry or to avoid quarantine. Some airlines are pitching COVID-free flights, available only to passengers with negative tests. Are any of the available tests accurate enough and timely enough to provide effective protection against transmission? I'd like to start that, and then I would like for my colleagues to jump in. First of all, remember that a negative test is a test at a single point in time. It doesn't tell you anything about tomorrow. It doesn't tell you anything about in 3 weeks. Also, you can't test yourself out of a pandemic. You still have to maintain social distancing, mask, and wash your hands. Does anyone else want to add something quickly to that answer?
I completely agree. I think that testing right before getting onto a flight just shows you that moment that the virus, either antigen or nucleic acid, wasn't detected at that point in time. And so just like testing in any other situation, we still need to be performing masking, social distancing, et cetera.
Yeah, I completely concur. No test is perfect either. There's other issues that could affect a test as well, including collection that we've talked about earlier. And so you can't use a test result as a guarantee of anything. And so if they do pitch COVID-free flights, they still need to do the masking that they've been requiring on those flights. They can't let their guard down. They need to still take precautions as they would, even if they weren't doing this testing.
Next, we have a question from the Washington Post. This is a question for the panelists. Does the expansion of testing programs by airlines and at airports have an impact on the overall testing supply? Dr. Wojewoda, why don't you start?
Yeah, it's interesting. Our airport, Little Old Burlington Airport, is offering antigen testing point of care and collection for PCR testing that's being sent out to a laboratory in another state. And that does offer residents in our area another option for testing that doesn't utilize our collection supplies or testing supplies in our healthcare system. So I do think that's another option. I just want to make sure that somebody, especially a pathologist, is involved in setting up that testing and ensuring that testing is being done appropriately, collection is being done appropriately, so that those patients can rely on those answers, just like they would if they showed up in our emergency department.
Dr. Karger?
Yeah, so similar to Dr. Wojewoda, our airport, our Department of Health set up a testing site, collection site in our airport, and they took care to try to avoid any impact on local testing capacity for healthcare systems by actually setting up from scratch a saliva-based testing lab in our state. Our Department of Health partnered with a company to do this. And so there's a saliva testing site set up in the airport that uses different supplies because it's saliva, so it doesn't use up the swabs that we need for clinical care. And then those samples are sent specifically to the saliva testing lab. And so that's been one way to try to avoid impacting directly what's needed for the clinical sites.
This question is from David Lim with Politico. What constraints do you see in terms of the supply chain for testing? And are you concerned that capacity will top out again in the upcoming months? Again, we've talked about some of this, but I am absolutely concerned that the capacity will top out again in upcoming months. For all the reasons that we've said, I can't get enough reagents. I can't get enough consumables to do the testing that I need to do now. So yes, as the numbers in my area, in rural South Georgia, in rural South Carolina, Alabama, and Florida, which is where I work, I believe those numbers are going to go up, and I am very afraid that I won't be able to test, to provide enough testing. What do my fellow panelists think?
I've heard it described as a game of whack-a-mole. So as soon as we get one set of supplies, then it's another set of supplies that we can't get our hands on. Right now, we're very concerned that we can't get tips, pipette tips that have a certain filter in them to transfer patient sample into the tubes that we need or the plates that we need to do the testing. And so if we can't get the patient sample into where it needs to go safely without making sure that we don't contaminate other patient samples, that's a big issue. And each hospital and healthcare system is dealing with this on their own, trying to fight for what they need to do the appropriate testing. So it's continuous, and as cases continue to rise, patient samples will continue to show up and increase, and I agree, we're going to top out.
Yeah, I definitely. Yeah, I was going to say, I definitely like the analogy of whack-a-mole. We're experiencing the same thing. And that's the problem, is that it's a moving target. It's not just one reagent. It's not just one supply. It's a different thing that's in shortage at different stages. At one point for us, it was the chemicals and some of the RNA extraction kits. At another point, gloves were a concern. And now we're also dealing with issues with pipette tips, as Dr. Wojewoda mentioned. But I also wanted to mention that this is not just affecting COVID testing. This is affecting other laboratory tests. There are ripple effects to the high demands for COVID testing, and it's impacting areas we wouldn't even necessarily expect. There are supplies that we need in our clinical labs that appear to have nothing to do with COVID testing, which we can't get right now. For example, pH strips we had an issue with. And every time something's in a shortage, it requires more work from our lab staff. They have to look for an alternative. And if they find one, they have to validate the performance of that alternative. And so we've had to validate multiple other types of testing materials and kits during this pandemic that have nothing to do with COVID. And so I'm concerned not only in terms of maintaining our COVID testing capacity, but also the impacts that this is having on other laboratory tests that we need to deliver to our patients. In Dr. Godbey, in your intro, you mentioned sexually transmitted infection testing. That's also a concern of ours. There's shortages with supplies for that as well. And there's a concern that there's going to be a lot of cases going undiagnosed if we can't provide enough testing in that arena.
To your point, in our lab, we no longer provide testing for gonorrhea or chlamydia on site. And the reason is we have to use those same consumables to perform COVID-19 testing. So one of the ways that we have had to adapt is to send those tests out, and that increases turnaround time. I'm looking forward to being able to bring those tests back in-house, particularly gonorrhea and chlamydia, but that's not going to be the case in the near future. Next question is from Emma Court with Bloomberg News. 1, how has supply of rapid tests fared in the latest COVID-19 surge? And 2, are doctors being encouraged not to test any populations of people, such as asymptomatic individuals, in order to preserve lab capacity or turnaround time? And if so, which group of test seekers are being affected? Let me start because we cannot get enough reagents, and I've made this point several times, but it can't be made enough. We have to decide which tests we can do in-house, which tests we need to send away, which test is most emergent. And that is a day-by-day decision. As we increase reagents, we increase buying, we do more in-house. If we're short, we don't. I'd be interested in what you think, Dr. Karger and Dr. Wojewoda.
Yeah, in terms of rapid tests, so because we were able to get our PCR testing up to such a high capacity, we haven't had to rely on rapid tests in our own health system. But I hear from other colleagues that those are also affected by supply chain issues. There, other sites that are reliant on those rapid tests aren't able to get enough tests to meet their needs. The other concern with rapid testing, which I mentioned earlier, is they have to be done one at a time. So in some locations, it's actually more of a staffing issue, and having enough people to actually perform those tests. And particularly in colder weather places where we've had curbside testing set up and now have to move operations indoors, space is at a premium. A lot of health systems are struggling with finding the space to do kind of rapid testing or kind of curbside collections, but now in an indoor space. In terms of not testing certain populations, again, with our capacity and our unique situation, we aren't limiting test seekers in our health system, but I do know in other locations where tests are limited that yes, they are. They do have certain criteria and are limiting testing of asymptomatic people, for example, or directing them to other testing locations. Like I said earlier, in Minnesota, we have this advantage of having the Department of Health setting up this saliva testing lab. And in Minnesota, people can actually get that test for free. That's being supported by our state. And you can have the collection kit even mailed to your home just by going online and requesting it. And so we are trying, throughout Minnesota, people who are asymptomatic or just curious if they're, a carrier, if they've been exposed, are being encouraged to use that as a potential option if their health system is short on tests.
Thank you. One more question.
We also haven't, sorry.
Oh, go ahead. No, please, go ahead.
I was just going to say, we also haven't brought rapid testing, antigen testing into our health system as we have been reliant on PCR testing, but our state is distributing antigen testing to nursing homes and congregate living facilities in order to screen residents and health and staff. And we currently aren't limiting any patient populations from getting collected like we had in the past. Very early on, we were only allowing symptomatic patients to be collected. Now we are allowing everybody to be collected, and that overflow will just have to go to a reference laboratory, which will take a little bit longer.
One thing I think it's worth pointing out when we talk about rapid testing in this discussion, we're talking about antigen testing. Antigen testing has, in general, good specificity, but in asymptomatic people or people who have had symptoms more than, if you've had symptoms in the first 5 to 7 days, many of the antigen tests are fairly sensitive. But again, pathologists need to be involved in which type of testing clinicians perform, and also how to help interpret those tests. Also, how will vaccine administrators know not to duplicate vaccinations in the same person? I think it's worth remembering here that vaccinations for the foreseeable future are going to be in very short supply. Duplicate vaccinations are not a possibility. I don't see as being a possibility anytime in the near future. Will there be some sort of national registry? I don't know, but pathologists are always interested in doing anything they can to benefit patients in any way possible. And if we could participate in some kind of registry, we would be willing to do so. Does anybody else have any thoughts on this question?
No.
Then there's a follow-up question, and if people are vaccinated more than once, either with primary or booster, could that cause harm? Again, the possibility of that is fairly remote at the present time because we can't get enough vaccine to vaccinate everybody who will want it. Now, in our situation, we've already decided tiers, and as my two fellow pathologists on the call have stated, I too am trying to make sure that my laboratory scientists are in a high tier because we can't do without them. Any other thoughts on this? No, all right. Let's see if we can get another question. This question is from David Lim with Politico. The diagnostic lobby has argued that there are supplies in the market that are not being utilized. In particular, I've heard that, excuse me, there are concerns that surveys of smaller labs aren't reflective of the overall landscape. While admitting that there are challenges getting specific products, I know Thermo Fisher in particular has been pushing its COVID tests and associated platforms. Specifically, the diagnostic lobby pushing back on CAP and other lab group assertions that there are overall constraints. Could you speak to specific shortages? Are you looking at pipette tips, reagents, either or swabs and transport media? I'm looking at shortage for all of those: pipette tips, reagents, and swabs. In my own lab, the situation on swabs has gotten better. When we first began to meet the challenge, we literally counted the swabs every day and reported the number of swabs in our conference each morning at 7 o'clock. We've been able locally to get enough swabs, but everything else you just mentioned is in short supply for us. Any other thoughts on this?
Yeah, we've had better luck with swabs, but transport media is difficult. So we've gone to saline. It wasn't something that we were used to using prior to this pandemic. We get a weekly allocation of testing supplies, pipette tips, and the chemicals needed for our testing platforms. I think the question is correct, and I'll let Dr. Karger speak more to it, that if you are using a laboratory developed test or tests where you can mix and match pieces and parts, you can usually keep up as you can plug different pieces in. But if you're using a manufactured test, you rely on exactly what the manufacturer gives you. And right now, they're only giving out little bits at a time in order to spread out the supplies across the country. And so we know exactly how many tests we're supposed to get in a week. And sometimes we don't get what we think we were supposed to get. So we watch those testing numbers very carefully.
Yeah, so I completely agree. There's only a limited number of labs that are going to be able to have the flexibility to switch around with different types of chemicals and supplies. And as I mentioned earlier, we were able to do that, but it required the expertise of our 2 molecular pathologists. And frankly, a lot of health systems don't have molecular pathologists at their disposal to design the type of procedure we had in place. And so that's something that's not necessarily going to be available for every health system. to do is to develop a flexible lab-developed test like that. The other thing I want to point out is that, as Dr. Godbey mentioned, labs have already invested in purchasing multiple instruments. And so there's only so much space and so much time to train on methods. We can't bring in all of the methods that are out there into a lab space. We have to pick and choose and hope that the ones that we select are going to be reliable with their supply chain. And the harsh reality is some of the methods and instruments we've chosen have not been able to provide a steady stream of the supplies that we need or that we thought we were going to get when we made the purchases to begin with. And I think that's the greatest frustration, is that we don't have room or time to bring in every possible method, every possible instrument. And so labs are going to be constrained in different ways depending on what specific instruments they have in their space. And that's a challenge. And I really feel like I haven't heard of many labs that don't have supply chain issues. So I think it is and remains an issue for the vast majority of laboratories at this time.
Last question, and this is from the Washington Post. Is there anything that can be done at the federal level in terms of helping with the supply chain, or is it too late in the pandemic? I'd like to make a point, and I think it's worth remembering, that many of the makers of reagents, instruments, and laboratory supplies are not headquartered in the United States, and important decisions concerning laboratory instruments, reagents, and supplies are not made in the United States. For instance, I talked about the shortage of swabs early in our fight against the pandemic. The company that made our swabs was in Italy, and the Italians were having large problems of their own. And we had to go out and find other suppliers, and we did find one in the United States that makes the swabs. But because many of the decisions are not made in this country, it does hamper some of our ability to respond. Does anybody else have anything to add to this?
I think the manufacturers of laboratory supplies are doing everything they can to pump out as many as they can that work well. And I was very impressed at the amount of FDA emergency use authorization tests that came out or were available for the laboratories in such a short amount of time. I've never seen testing come out that quickly. I think the problem is we just have never seen this amount of samples for any one thing ever. And so, these companies back in, a year ago, were not thinking that they were going to need to be making COVID-19 testing supplies and at this rate. So I think the only thing that could have been done was to slow the pandemic down way early so that we wouldn't have to be testing this many samples this far into the year.
Yeah, I would totally agree. I mean, this is just an unprecedented amount of testing that hasn't been seen on the manufacturer level for one given test and at the lab level. But it is true that a lot of these issues are outside of our control, as Dr. Godbey mentioned, with some things being manufactured outside of the U.S. One thing I will say that has been successful in Minnesota as part of that statewide testing command center is there is a logistics team that has been bringing supplies in and trying to distribute them out to rural areas where they don't have someone who can spend as much time on supply chain issues and hunt for the things they need. And so I do think perhaps at the federal and state level, there could be more coordinated efforts at identifying where supplies are and getting them to the places of greatest need. And we have had that luxury in Minnesota of being able to distribute things more equitably. But yeah, I mean, I think supply chain is the greatest challenge. And I think what's also frustrating is as many tests as there are on the market, and I'm always glad to see new tests being developed. I feel like, and I know a lot of labs feel like, we have enough tests in our lab. We have enough instruments. If only we could just get enough supplies. Like, I don't need any more PCR tests developed. It's nice to see that innovation and see those developments happening. But at this point, we have invented enough tests and instruments to do testing. We just don't have the supplies to do the amount of testing we want to do.
I think it's worth pointing out that we started from ground zero, and both of you made this point. Pathologists and the laboratory scientists that we work with and direct truly have been heroic in their efforts to answer the need. We've adapted, we've changed, we really have done extraordinary things. And I think that the laboratory scientists, again, and the lab, people who work in the labs, need to be congratulated and need to be lauded for the work that they've done today. Every pathologist, every laboratory scientist wants to do the best they can. And at this time, they have truly shown. We're about out of time. My thanks to Dr. Karger and Dr. Wojewoda for their valuable insights today. Please reach out to the CAP, as pathologists are the authorities on and valuable resources when it comes to testing. On behalf of the College of American Pathologists and our members, we urge you to wear a mask, practice physical distancing, and wash your hands frequently. We also urge everyone to follow the CDC updated guidelines concerning travel during this holiday season. The CAP supports these guidelines. Please stay safe, and we look forward to talking again in 2021.